assessment process for fluency disorders. Typically, we begin the assessment with description of the problem and baseline measurement. So we're going to be counting the frequency and type of stuttered words during spontaneous speech and or a oral reading task. We're also going to measure speech rate, and we're going to count and describe secondary symptoms. So those were the behaviors I was mentioning earlier, such as circumlocution behaviors, any type of body movements, facial movements associated when the person is having a episode of disfluency. And then we're going to rate the severity of the disorder according to the descriptions of mild, moderate, or severe. We're also going to assess the emotional and cognitive reactions to stuttering that the individual may have, and any anxiety or negative feelings they may have when they think they are going to stutter, and any type of avoidance patterns and that they may have due to the stuttering disorders and any other effects on their quality of life. We're also going to assess the environment and the family-client interaction style of the individual. So before I discuss this slide, I also want to mention that the formal tool for assessing an individual with a stuttering disorder would be the Stuttering Severity Index. And I will post some photos and maybe just a brief video clip of that instrument just so you get to see what that is. And that's a very commonly used assessment tool for individuals who do have a stuttering disorder. And it goes through those different areas that I mentioned on the previous slide, and gives you more of a format to score the different areas that are assessed during a fluency assessment, and then be able to use those scores to categorize the individual's stuttering disorder as being either mild, moderate, or severe. So additional things that you need to consider when you're doing a fluency assessment, in that according to Adams research that they had done, that a child can be considered normally disfluent if they have 9 or few disfluencies per 100 words spoken. So if you have a 100-word speech sample and you have counted 9 or less disfluencies in that 100-word sample, then that can still be considered normal. So just to reiterate that all of us at times have disfluent patterns in our speech, and that's still considered to be normal. In addition, as I mentioned earlier, if a child primarily emits a whole word or phrase, repetitions and or revisions, so starts and stops, and then they start a utterance and then they stop and then rephrase it and begin again, that's still considered to be normal disfluency, especially among young children who are developing language. So also, again, the child is showing no effort or tension when initiating an utterance, and the child does not substitute a schwa vowel for the appropriate vowel in a part word repetition. So the example of, again, the schwa vowel is the sound. Okay, so when a child is demonstrating more a concern with true stuttering behavior, you'll hear the sound inserted when they're trying to then speak a word or an utterance. So the example would be if a child was trying to say the word basket, then if they were stuttering at the beginning part of the word, it would sound like basket. So I'm inserting that sound and repeating the initial consonant several times before I'm able to actually get the whole word out. So according to Van Riper, the criteria for a true stuttering diagnosis, these are the different listings of the criteria according to Van Riper, in that an individual should have part word repetitions of 2 or more units per repetition. Okay, so my example was when I was disfluent on the word basket earlier, I was repeating the b sound several times before I was able to get the word basket out. So it's again the repetitions 2 or more times per repetition, okay, on 2% or more of words uttered. Okay, and you may see an individual increase their speech rate, okay, when they are having an episode of disfluency. And like I mentioned earlier, the use of the schwa vowel, the sound, and inserting that sound in the word, as well as observable vocal tension. So there's a lot of strain and effort being seen in the laryngeal area, possibly in the articulators as well, to try and get that word out. Prolongation. So if an individual is trying to say a word and they're phonating longer, okay, than 1 second on, again, 2% or more of the words uttered. Okay. There could be an abrupt termination of prolongations, and then you notice the individual's voice increases in pitch and loudness. Involuntary blocks. Okay, so an individual could get, so to speak, stuck and actually not be able to get phonation or actually produce any voicing to actually utter the particular word that they're trying to say. So it's called a block. So it's a block or hesitation before they're able to actually start to phonate and say the word that they're intending, and that is longer than 2 seconds in the natural flow of speech. I mentioned earlier about those secondary behaviors. Okay, so the examples specifically of those secondary behaviors would be body movements, eye blinks, lip and jaw tremors, and obvious signs of struggle, okay, that are associated when the individual is having a stuttering event. Emotional reactions and avoidance behaviors associated with speaking. So negative feelings, having anxiety over having to speak, and knowing that they're going to be disfluent or have a stuttering event. And then because of that, they start to avoid certain situations that they would be embarrassed about their stuttering disorder and their speaking skills. So to talk about therapy for stuttering, there are many different approaches to therapy for stuttering, and the approach can depend on the age of the person. Okay. And fluency shaping therapy and stuttering modification therapy, and as you'll notice in the next bullet, combination of those two approaches are the most popular intervention approaches for intervention for stuttering. So with with fluency shaping therapy, we're going to instruct and demonstrate ways the client can systematically increase the speech that is free of stuttering. So we're going to engage in lots of activities with the individual that promote a lot of fluent speech, okay? And we're going to maximize and try and engage in those types of activities more than other activities we notice in situations where the individual is demonstrating a lot of disfluency. Stuttering modification is actually using specific strategies to modify the stuttering moments. And when an individual is able to learn some of these therapy strategies to alter what's happening with their speech, they feel like they have a little bit more control over their stuttering disorder, and then working with that individual to then lessen the avoidance, effort, and struggle that's seen in older children and then adults who continue to have a stuttering disorder. So like I mentioned, therapy often involves integration of both fluency shaping and stuttering modification therapies, and oftentimes clients benefit from both of those strategies. And just to mention here that the fluency shaping and stuttering modification, they're typically used with school-age children who have been identified as having a chronic communication disorder. Okay, so as I was mentioning, that again, the fluency shaping and stuttering modification therapy approaches are used with children, school-age children who have an identified chronic stuttering disorder, and older children and adults. Just to mention on this slide as well is electronic devices. These can be considered when the client has stuttered for a significant period of time. They're usually used in a type of clinical setting, and again has to be monitored and used by an SLP who is trained to fit the particular device. These devices aren't used as commonly. They're mentioned in your textbook, and they basically help with biofeedback and the adult being able to monitor and be more aware of what's happening when they are having a stuttering event, and to learn how their body feels and how they feel actually when they're producing fluent speech over what's happening when they are stuttering. Okay, so intervention for young children. Just down a little bit. Okay, is a little bit different than the strategies I mentioned earlier, which would be more for a school-age child who's identified as having a stuttering disorder. So with young children, there is, when intervention is provided very early, okay, there is more of a chance for that stuttering disorder to diminish. So with young children, the programs vary and are a little bit different than some of the programs I mentioned earlier. So one of the parent-directed programs is the LidComb program, and I did provide extra reading materials specifically about the LidComb program in this training module. But basically with young children, we try to encourage the parents to be very involved in the therapy process, because most likely they're the ones to be around the child the most and be able to follow through with the strategies and good that the parents provide the treatment to their child once they have been trained by an SLP for, again, proper use of the techniques and interaction style. So the LIDCOMB program was developed back in 2003 in Australia, and the philosophy again is that the parents actually do the more direct ongoing treatment, okay, with the child, and it's for children 6 years of age and younger, so it's for younger children. And with the LIDCOMB program, the goal is actually to really get rid of the stuttering disorder and behaviors or disfluencies, and really diminish it altogether. So with the LIDCOMB program, as you'll read in the handouts that I have in Blackboard, in that the parent learns to give feedback to the child, which isn't negative, but does give feedback and addresses the child's speech in asking them to think about if their speech is bumpy or smooth. Okay, and so you're bringing attention to the child that their speech again could be bumpy, so we're not using stuttering or some other types of words, but we're kind of referring it to as either bumpy or smooth speech. And then if the child does demonstrate some disfluency or bumpy speech, then the child's actually able to asked to re-say that utterance again using smooth speech. And it's not done all the time, but it's done at certain periods during the day to help promote more fluency in the child. So this slide talks about some more approaches for young children for stuttering therapy. And one approach could be called indirect therapy, and that's when we do some environmental manipulation, meaning that we're looking at the environment to see if there's a lot of chaos or stress going on, pressures for the child to speak quickly, if there's again some emotions, anxiety in the child. Want to try and diminish that or get rid of that in their current life. And we also want to provide parent and family counseling. Okay, so we want to encourage that the parent be positive about their child's communication skills, and we don't want the parent to be providing negative criticisms and or other types of feedback, such as telling the child to hurry up or don't stutter, or adding more pressures to the child, or more possible negative feelings about the child's stuttering disorder. So this goes back to the earlier set of the slides, in that no, a parent doesn't cause stuttering, but if they do have negative reactions and criticisms to the child about their stuttering, that definitely can make the situation worse. So we want to make sure that the parent is reinforcing, okay, the efforts of therapy by the SLP if the child is seeing a therapist directly for treatment, rather than counteracting, okay, the efforts. So direct therapy also now can involve desensitization situations. So it's a form of direct work with the child, but we're not necessarily going to work directly on the child's disfluency. Okay? So we're going to create an environment where there is no stress, okay? And we're going to engage in activities where the rate of speech is slow baseline data to see the levels of fluency when we do manipulate the environment and make it as stress-free as we can. Okay, and then we're going to engage in play-based activities, again, to reduce the dysfluency to the lowest level. Okay, so like I said, we're going to take some baseline data to make sure that the child has a basal level of dysfluency. Okay, and these activities may be actually the beginning interacting non-verbally, and then with parallel play, and then gradually introducing more verbal communication into the therapy sessions, okay? And then gradually increasing the child's tolerance for stress as they're increasing their verbal communication, and hopefully still maintaining low levels of dysfluency. And again, the family members usually watch the session with the SLP to learn these strategies to be able to then carry over these types of interactions in the home environment. So as I was mentioning before, if a parent does have some interaction styles which aren't conducive to fluency, then we would model for the parents good interaction styles, okay, and activities which we see the child have more fluency, and activities that are a slower pace, less pressure to speak, and less stressful. And we would then model that to the parents, okay? And then the parents, again, are introduced into the therapy session, okay, to learn more productive forms of verbal interaction, again, to use at home. Okay, so to conclude on the last slide here about therapy for advanced stuttering. So for adults who may continue to have a chronic stuttering disorder, some of these strategies are mentioned again in your textbook, and it really can vary. I mentioned earlier about more chronic or advanced stutterers have biofeedback as a strategy that's used more in a clinical setting with equipment. Some other strategies could be use of psychotherapy to really work on the anxiety associated with stuttering, and counseling as well, to try and encourage the individual to not avoid certain speaking situations. It could be working with that individual to try and get over their anxiety and fears about these particular speaking situations when they are particularly disfluent, and actually working with that client to overcome some of that. Deliberate, easy stuttering, training the individual to, even though they're going to stutter, there are certain strategies that then they can use to actually stutter more easily, and not demonstrate some real long blocks or prolongations that really draws a lot of attention to their communication. So again, with the adult who has a chronic stuttering disorder, it's a combination of these different strategies, and Really the goal for adults in therapy for stuttering is to really help the client learn to communicate effectively and make sure that they're able to engage in quality interpersonal relationships, accept that they are going to stutter, but even though they do stutter, to continue on communicating and not avoiding life and relationships and situations. I will be posting a couple videos from the American Institute of Stuttering with adults who received treatment in the module as well, that you can take a look at those, which kind of sum up here on this last slide some of the intervention strategies